Souvik,
Yeah.
we are live.
Good evening and welcome to the expert crosstalk on Empagliflozin, multi-pronged, multifaceted, and multi-benefits. As we already knew that ESC 2020 was memorable with the path-breaking clinical data presented from multiple global trials. This program is designed with the objective of dialogue between two different specialties, cardiology and endocrinology, which bring upon two different ways to address the complexities of the clinical cases in heart failure. So according to temporary issue of trial, the SGLT2 inhibitor may be considered as an important drug for HFrEF. And for this, let me introduce today's speakers. Today's speakers are Dr. Saqib Ahmed Khan and Dr. Avinash Kumar Singh, and I am with moderator Dr. Shobhi. Dr. Saqib is a director, Department of Endocrinology, Chandan Hospital, and also New Life Endocrine Center in Lucknow. Doctor has got several national and international publications in his credit and also has delivered lectures in many national conferences and CMEs. I welcome Dr. Saqib in this expert workshop. Our next speaker is Dr. Avinash Kumar Singh. Dr. Avinash is a consultant intervention cardiologist at LPS Institute of Cardiology. His specialization expertise in complex coronary and peripheral intervention, balloon valvulotomy, arrhythmia management, pacemaker, ICG, heart failure management, and many more. Dr. Avinash has got several national and international publications in his credit and won several prestigious awards till date. I welcome Dr. Avinash in this expert workshop, and I am handing over the session to Dr. Saqib to start with the presentation. Thank you.
So thank you, Dr. Shomik. Thanks for the nice words.
Welcome.
So today we are going to. So good evening, everyone. So today we are going to discuss empagliflozin. We know that initially we have many reservations against this molecule. Some of us have skepticism that how a drug which actually enhances the problem which is causing more glycosuria, which was the first investigation by which we used to monitor the patients for their glycemic status would be good for a patient or not. But now we have seen enough data are showing us that not only they are able to control glycemia, but also they are able to have a lot of benefits, like they even can be considered for their their benefits in terms of CV mortality reduction, their chances of reducing hospitalization for heart failure, even in those who are having even those who are having heart failure with reduced ejection fraction, whether they are having diabetes or not. So we'll be discussing that. We'll be seeing the evidences, and we'll be seeing what can be the way forward. So I will just be looking for the endocrine or diabetes perspective. So SGLT2 inhibitors, we have a lot of data about different molecules of this class SGLT2 inhibitor. DEPA has come with the publication about this molecule in March 2008, followed by rimogliflozin, followed by canagliflozin, and then empagliflozin in 2010 and then 12. So we know that how it acts. So it is mainly the SGLT2 receptors in the proximal part of glomeruli, where it acts. Some other new molecules are being planned, and then they are being investigated, where SGLT1 inhibitor function can also be combined. And we know that the daily filtered glucose load is more than 180 gram per day. So if we, and actually it has come from one observation that some group of people have seen that in those people who are actually having this SGLT2 inhibition or kind of down regulation SGLT2 of SGLT2 gene, they are having a kind of more glucosuria in them, and so they are protected for the development of diabetes as well as for obesity. So this has led to the discovery of SGLT2 inhibitor from apple bark, and then ultimately it is synthesized, and further studies has taken place. So they reduce glucose reabsorption in the proximal tubule, leading to urinary glucose excretion and osmotic diuresis. So they are a kind of diuretic where disproportionate glucosuria occurs as compared to saline diuresis. So saline diuresis is very less as compared to glucosuria, and so you lost more and more calories as well as glucose from your urine. So if you compare the pharmacological properties of available SGLT2 inhibitors, so we have empagliflozin, dapagliflozin, and canagliflozin, and we are using it. And therapeutic dose of empagliflozin is 10 to 25 milligram once a day, and of dapagliflozin from 5 to 10 milligram, and canagliflozin in 100 and 300 milligram once a day dosages. So administration is once a day for all of them. Absorption is good for all of them. Metabolism is primarily glucuronidation in the liver, so and no active metabolite occurs. Elimination is almost equal from hepatic and renal route in case of empagliflozin, almost predominantly renal in dapagliflozin, and predominantly hepatic in canagliflozin. So selectivity as compared to SGLT1 is more than 5,000 in IMPA, more than 1,400 in DAPA, and more than 160 in CANA. So so this is the reason why glucose excretion is more with canagliflozin, because it also has action on SGLT on SGLT1. So the pooled data shows us that if you uh, see that they can be used as a monotherapy, or with metformin or pioglitazone, or with uh, or up and above the combination of metformin plus sulfonylurea. They can be used with any of the existing options. They can be added on basal insulin, they can be added on basal bolus insulin, they can be given in mild renal impairment, and if you use 10 milligram or 25 milligram, you have HbA1c reduction from minus zero point 0.5 to 7 or so approximately minus 0.6 to 0.7 percent of HbA1c reduction takes place, irrespective of the already received prescription by a patient. So you can add, and you can have a median HbA1c reduction of minus 0.62 by the usage of empagliflozin 10 milligram once a day, and 0.68% HbA1c reduction by the usage of 25 milligram once a day empagliflozin. So if you see that what kind of effect it has on body weight, so it can lead to minus 1.8 to minus 2 kg loss from the baseline, uh, if you talk about 10 milligram or 25 milligram respectively. So they can be used as monotherapy superimposed on metformin, which is actually a weight neutral drug, but it can have some 2 to 3% of weight loss in selected group of patients. Pioglitazone, which actually leads to weight gain and fluid accumulation. It can be combined, and it can offset that problem of fluid retention of pioglitazone. We know that after iris trial that it can be good in those patients who are having previous stroke. So but the problem of fluid accumulation, and so because incipient or overt CHF can exist in any patient who is having CVA. But this fluid accumulation can be offset when we use simultaneously SGLT inhibitor also. So metformin plus sulfonylurea can also lead to some sort of weight gain due to sulfonylurea, and we can offset this weight gain with the usage of empagliflozin, and it will be effective with the any kind of combination. Even in mild renal impairment, it will lead to a significant weight loss. So if you talk about systolic blood pressure, because I've already said that it is a kind of diuretic which has disproportionate osmotic diuresis of glucose molecule as compared to saline diuresis. but still because of some saline diuresis, it leads to systolic blood pressure reduction, and it can be up to the tune of minus 3.5 3.4 millimeter Hg when empagliflozin 10 milligram is used, or 3.8 milligram reduction when empagliflozin 25 milligram is used. And the loss would be significant and apparent in with any kind of complication, with any kind of combination. So ambulatory blood pressure monitoring is a very wonderful tool in selected group of patient, and even in setting where we are going for analytical purposes, like for for different studies. When you give empagliflozin, it shows that there is a significant reduction throughout the day, when it is compared to placebo. So both the dosage 10 milligram as well as 25 milligram leads to a dip at every point of time when you have a data of ambulatory blood pressure monitoring. So and the good thing is that this reduction in blood pressure was not associated with increase in pulse rate, which is the usual problem with diuretic usage. When you have contraction in the volume, when you will be having more tachycardia, which is not the case with the usage of flozins. So this is the 12-week ambulatory blood pressure monitoring study with empagliflozin in patients with diabetes and hypertension. So early mean diastolic blood pressure was also less. So though it is not only the systolic blood pressure, diastolic blood pressure will also be benefited, because it leads to decrease of both preload as well as afterload. So this decrease of afterload will lead to decrease in diastolic blood pressure also, and this reduction is also not associated with increase in pulse rate. So effects of SGLT2 inhibitor on glucose control, blood body weight, and systolic blood pressure, as we have discussed in last few slide, is evident, whether you talk about monotherapy or you talk about add-on metformin or add-on to sulfonylurea or add-on to pioglitazone. So it is significant across the stage, and it is significant. So you can have further benefit. We know that diabetes is a progressive disease, diabetes is a dynamic disease. With the passage of time, you require multiple agents to combat further rising hyperglycemia, and we know that the purpose of diabetes treatment itself is prevention of complication. So it is another tool which can be added. And one good thing is that the mechanism of action of this class of drug is duration independent. Like sulfonyl, we know that beta cell destruction takes place in any diabetic patient, and this can be 4 to 6% in elderly patient, while it can be as high as 8 to 10% if the patient is having diabetes in his young age. So with the passage of time, sulfonylurea, which acts as a secretagogue, will not be able to act in as strongly as it was working in the previous years. So, but SGLT inhibitor can have a good action irrespective of the duration of diabetes. So it is a good thing. So if you see the pooled safety and tolerability data, so summary of adverse events. So if you compare with the placebo, empagliflozin 10 and 25 milligram, both are very safe, and rate per 100 patient year is low, even as compared to placebo. So though we have to select our patient judiciously for empagliflozin. So those patients who are predisposed for UTI, that is those who are having postmenopausal those who are postmenopausal women, those who are having a recurrent history of UTI, those who are having a very advanced age, and they are predisposed for this kind of complication, those who are having insulinopenia, and are not on insulin, those can be the person who can have genitourinary problems, or even the possibility of remote chances of euglycemic decay. But if you select them judiciously, the chance is very rare, though it still exists, but the chance is very remote. So patients with adverse effect leading to discontinuation is even lesser, and patients with serious adverse effect is lesser as compared to placebo. So they can be very safe when you select them judiciously, and tell them that you are going to take an agent which will lead to glucosuria. So you will have to take some extra water in the daytime, so that you will not be having any urinary problem. And then you will have to inform whenever you will be having any genital mycotic infection or UTI. So you will have to you will have to be vigilant, and you will have to make it a point in your prescription. So if you talk about empagliflozin and cardiovascular outcomes in patients with type 2 diabetes mellitus at high cardiovascular risk, so we already know that the most common cause of mortality as well as morbidity in a diabetic patient is cardiovascular. So any drug which is doing good in terms of cardiovascular risk reduction would be doing good in diabetes mellitus. And we know from 2019 we have changed directives. So even ADA, which is mostly followed across the world, in 2019 it has said that even after metformin, if the patient comes to you, and uh, the second line of drug should be SGLT inhibitor or GLP-1 receptor agonist, if the patient is having if the patient is having a strong ASCVD risk factor, or if the patient is already having a developed ASCVD. Even European ESC has said that even it can be given before metformin in those patients where it can have a wonderful effect, which will be discussed in the latter part of this presentation by Dr. Avinash. So empiric outcome trial has shown that if you talk about renal outcomes, also not only this cardiovascular outcome, we know that microvascular complication is a big nuisance in neuropathy, nephropathy, and retinopathy. Uh, they are a nuisance for any diabetic patient. So if you talk about incident or worsening nephropathy, it can be minimized, and it can be reduced to the tune of 39% with the usage of empagliflozin as compared to placebo. So 39% reduction with the hazard ratio of 0.61 is very good. And there was 38% reduction in terms of progression to macroalbuminuria. And there was a 46% decrease in composite renal outcome as compared to placebo. So this is a huge data in terms of support of empagliflozin. So in patients with type 2 diabetes and high cardiovascular risk, empagliflozin given in addition to standard of care, it was able to reduce heart failure, hospitalization, which will be discussed in the next part, or cardiovascular death, with a consistent benefit observed in both those with and without heart failure at baseline. So So how early after treatment initiation are the CV benefits of empagliflozin apparent? A post-hoc analysis of empiric outcome. So it has just shown us actually the the evaluation of this empiric outcome uh, was having a line that it is too good to be true. So it is very early. So it bifurcates the decreased CV death and then decreased hospitalization for heart failure occurs very early, and this is a very important and very discriminating feature, which makes these two classes, SGLT and GLP-1 receptor agonist, a very useful one in those who are having strong ACVD risk, and in those who have already developed ACVD, especially SGLT2 inhibitor. So in the empiric outcome trial, it has showed CV benefits with an early separation of the cumulative incidence curves. uh, ex- eh, eh, so ex- so we will exploring at what time after randomization benefits became apparent, hazard ratio stabilized as number of patients with events increased over time. Benefit of empagliflozin in reducing risk of hospitalization for heart failure, CV death, hospitalization for heart failure and CV death emerged within weeks. So initially people were quite puzzled that how a drug which is decreasing glucose is able to make this much of difference by just reducing uh, uh, glycemic level. It is too good to be true. So but it is actually evident when the data was further dissected. So if you see, so reduction in risk with empagliflozin versus placebo reached significance at just day 17 for hospitalization for heart failure, and it was significant. And day 27 for cardiovascular death and hospitalization for heart failure with hazard ratio of 0.28. So it was a reduction of 72% with a significant value, and it was sustained significantly throughout the follow-up. So it is a huge benefit, and it comes very early, and it remains throughout the follow-up. So successive hazard ratio for empagliflozin versus placebo for hospitalization for heart failure and CV death hospitalization for heart failure with a vertical line demonstrate that you can have a very lowered risk for hospitalization for heart failure as well as CV death very early, and it remains separated for a long follow-up. And it was presented in ADA 2020. So if you see this forest plot, so it is showing that if you talk about effectiveness and safety of empagliflozin routine care patient, so this is emprise study. So if you compare empa versus DPP4 inhibitor, so they have a clear cut benefit in if you talk about hospitalization for heart failure. And if you talk about broadly, it is still very significant, it is not crossing the line. So confidence interval is good. So myocardial infarction or stroke, there is some benefit which is not significant because confidence interval is crossing one. MI was also less, but it was not significant. Ischemic or hemorrhagic stroke was less, but was not significant. All cause mortality was significantly less, number of events were less, and hazards ratio was 0.52. That means that there was 56% reduction in all cause mortality as compared to DPP4 inhibitor, and this is a huge benefit. So in subset of population with complete mortality information, empagliflozin was associated with a decreased risk of all cause mortality compared with DPP4 inhibitor, as well as if you talk about hospitalization for heart failure and a similar risk of MI or stroke, it was having a reduction of 58% as compared to DPP4 inhibitor. So we know that after the debacle of rosuvastatin, CV safety trials are being conducted for uh, rosiglitazone. CV safety trials are being conducted. So we have saver-timi for sexagliptin, examine, tecos for sitagliptin, elixa, sustain leader, and so on and on. And uh, SGLT2 inhibitors modulate a range of factors related to cardiovascular risk. So based on clinical and mechanistic studies, so we know that initially we were taught that diabetes is a heterogeneous disease, but it is mainly caused by either insulin excess or insulin resistance. But now we know that there are at least 11 factors. There are aggregate is 11. So if any drug is acting through multiple pathways, it would always be a good drug. So it leads to decrease in blood pressure, decreases in arterial stiffness, decrease in sympathetic neuronal activity, decrease in weight and visceral adiposity. We know that there is a YY paradox. With the same BMI, we tend to have more visceral fat, and because of this, probably we are having diabetes at least 1 decade earlier, and cardiovascular disease at least one or two decades earlier as compared to our Western counterparts. It also leads to decrease in oxidative stress. It leads to increase in LDL, which is not significant. It also lead to increase in HDL and in decrease in triglyceride. It leads to decreased glucose and then decrease insulin, and it leads to decrease albuminuria. We have seen that it can lead to so much of benefit in terms of decrement in GFR with the passage of time. Decrease uric acid due to decrease inflammation and decrease metabolic syndrome. So guidelines, as I already said, that even 2019 ADA and ESD, they used to say, and even in 2018 report, they say that metformin is not necessarily considered as first line drug therapy. uh, Drug naive patients or patient on metformin, irrespective of level of HbA1c, if they have a CVD or high or very high cardiovascular risk, you should start with, or you should add SGLT inhibitor or GLP-1 receptor agonist after metformin. So I will just stop here and I will hand over this presentation to my colleague, Dr. Avinash.
Dr. Saqib, sorry, Dr. Ravi.
Yeah. I'm listening.
Dr. Avinash.
Yeah, I'm
Okay,
connected.
fine.
I'm opening my slide.
Is there any problem sharing the screen, sir?
Yeah. Actually, I'm facing problem. Give me a few moments. I'm trying to connect it.
Fine. You just come.
Okay. Okay. Hello.
Yes, doctor, it's perfect. You can start.
Hello. Hello.
Yes, sir.
Okay. So good evening, everyone. I'm Dr. Avinash, and I'm an interventional cardiologist at Medanta Heart Institute, Lucknow. So first of all, I would like to congratulate Dr. Saqib for his excellent presentation. It was my pleasure to share this platform with such a eminent endocrinologist of our city. So taking this discussion forward, so this SGLT2 molecule is it is approved for the management of type 2 diabetes mellitus, and it has been recently investigated in several large placebo controlled trial for the cardiovascular safety and efficacy in the heart failure management, as well as other part of cardiovascular risk reduction. So these are the various mega trials which has given us hope in treating the patients of cardiovascular high cardiovascular risk factors patient. The first trial of cardiovascular outcome trial, it was Empagliflozin outcome trial, and it was for Empagliflozin, and it has shown us that the cardiovascular risk can be reduced by almost 35 to 38% by starting Empagliflozin over the standard of care medicines. Second trial which was published was Canvas program, and it included two trials. One was Canvas trial and second was Canvas R renal trial, and the third trial was Declare TB. So on the basis of these three trials, we can say that this molecule has class effect on reducing the heart failure hospitalization in patient with diabetes as well as patient without diabetes. Second, the class effect also has been seen in protecting the renal function in all these three trials, which was mega trials for SGLT2 inhibitor. The third one is the cardiovascular death. It was seen in empiric outcome trial that the cardiovascular death was reduced statistically significantly in patient who was started on empagliflozin with the standard of care medications for heart failure as well as for other reasons. But the benefit was lesser in Canvas program, and it was lesser in Declare TB trial, which was for dapagliflozin. So as a class effect, we can say that this molecule is effective in preventing the hospitalization for heart failure, and it is also giving good protection for our kidneys in patients with diabetes as well as patients without diabetes. So these are the results of empiric outcome trial. You can see the benefit started, which already described by Dr. Sakib, that the benefit started in the very beginning, because even in the first 6 months, it was better controlling the cardiovascular risk as compared to placebo. You can see this benefit was persistent in follow-up, and after 48 months of follow-up, you can see that the benefit is much better as compared to placebo. Similarly, in CV death, the benefit is, you can see, started from the very beginning, and it was persistent throughout follow-up, and it was much better during this 48 months of follow-up. Death from any cause, the same result was seen in this outcome trial, and hospitalization for heart failure, it was significantly reduced by adding this empagliflozin molecule over standard medications for heart failure. So this molecule is better. It was proven in this empiric outcome trial that empagliflozin is much better in reducing the cardiovascular events in patients with diabetes and patients without diabetes. So this is the Framingham Heart Study, which has shown us that the major cardiovascular event which used to occur in diabetic patients are cardiac failure. So the main emphasis was to see whether this heart failure incidence is reduced by adding some newer molecules in our standard of care medications. So other you can see the other risk factor, other cardiovascular diseases like coronary artery heart disease, intermittent claudications are lesser as compared to this cardiac failure. So all the major trials, they have shown that heart failure is more common outcome in diabetic patient as compared to MI or death in diabetes mellitus trial. So these are the various trials which has shown that the number of heart failure events are much more common in diabetic patient as compared to this MI stroke. So coming to the glycemic control, which is important for diabetic patients along with multiple cardiovascular risk factors. So in that we can see the intensive glycemic control is important for reducing the myocardial infarction incidence. These are the various trials which has shown that the myocardial infarction incidence can be reduced with by having this tight glycemic control, which we have seen in this ECHO trial, advanced trial, UKPDS trial. In advanced trial, it was a little bit towards the this neutral line, but overall, the efficacy of reducing this myocardial infarction events, it was better with intensive glycemic control. Similarly, the admission to hospital or heart failure events, it was almost not very by this intensive glycemic control, like in the core trial, it is not showing beneficial, but in advanced trial, UKPDS trial, it was showing some benefit, but it was not statistically significant. So overall, the effect is neutral. These are the heart failure outcome in clinical trials of glucose lowering agent in patient with diabetes. So coming to these evidences for the benefit of SGLT2 inhibitors on heart failure risk in patient with diabetes. So in EMPEROR trial, we have screened almost 11,531 patients, out of which we randomized only 7,020 patients, and they were divided into 3 arms, and one arm was given empagliflozin 10 milligram, and second arm was given this 25 milligram of empagliflozin, and it was compared with this placebo. So the inclusion criteria was adult patients with type 2 diabetes mellitus and established cardiovascular risk. And in this trial, the patients included, they have almost 10.1% of population having heart failure at baseline. BMI was less than 45 kg per meter square. HbA1c was 7 to 10%. eGFR was 30 ml per meter square. So if we'll see the results, the 3-point major adverse cardiovascular event, it was lesser in empagliflozin group as compared to placebo, with hazard ratio of almost hazard ratio of 0.86, with almost 14% reduction in the major adverse cardiovascular event in empagliflozin arm. CV death was reduced significantly with hazard ratio of 0.62 in empagliflozin arm as compared to placebo, and non-fatal MI and non-fatal stroke, it was also reduced in empagliflozin arm, but it was not that much significant. So this is the heart failure outcome in clinical trials of glucose lowering agent in patient with diabetes. You can see after adding this empagliflozin molecule over the standard of care medications for heart failure, the benefit started from the very beginning. You can see this event survival graph is it is separating from very beginning. So the benefit start from the very beginning, and it was persistent throughout the follow-up, and the benefit is very high, and it is all statistically significant with hazard ratio 0.65 with relative risk reduction of this cardiovascular event is almost 35. So these are the various mechanistic these are the various mechanisms by which we can say that this molecule is better in managing the heart failure patient. So it helps us in improving the left ventricular hemodynamics by reducing preload. Preload is reduced by this osmotic diuresis and natriuresis, and by decreasing afterload, and afterload is decreased by decreasing the arterial stiffness and decreasing the pressure inside the arteries. So it was proven in various studies that this molecule is helpful in reducing the LV hemodynamics. The third point is it also helps us in reducing the it helps us in increasing the fuel availability, like it helps us in changing the energetics of cardiac myocytes by supplying the ketone bodies like beta hydroxybutyrate for energy production, which is very good for failing myocytes in the heart failure patient. It also helps us in improving the kidney functions and cardiorenal physiology, and it helps us improving the endothelial dysfunction, which is very common in cardiovascular disease patient, as well as it helps us increasing the glucagon secretion, which so overall all these factors are improving the cardiac index, as well as it is reducing the afterload and preload, which is also reducing the LV wall stress. So these factors are combined. You will see that these factors help us in reducing the risk of hospitalization as well as mortality and morbidity in patients of diabetes and in patients without diabetes. So these are the various choices which we have today, with therapies like statin, BP control with calcium channel blockers, thiazides, SGLT2 inhibitors. These are helpful in preventing the heart failure, and it was very well proven in various trials. Other therapies which have only which are only proved to be helpful in treating the established heart failures like ARNI, ivabradine, device therapies like CRTs and ICDs and mineralocorticoid receptors. These are having very good data to show that these medications and device therapies are helpful in treating the patients with established heart disease. The third group is having both the having both the data regarding treating the established heart failure as well as preventing the heart failure events in patients who are predisposed for future heart failure. Like these are ACE inhibitors, ARBs, beta blockers, and exercise. So coming to this newer trial which was published in NEJM in 2020, August 2020, and main investigator was Mr. Milton Pepper. So this Emperor-reduced trial was it included patients with NYHA class 2 to patient with symptoms of NYHA class 2, class 4, and having ejection fraction of less than 40%, with elevated anti-proBNP levels more than these cutoffs, which were defined on the basis of ejection fraction. If the ejection fraction is less than 30%, then the value is 600 picogram per ml in patients with without atrial fibrillation. If patient is having atrial fibrillation, then this value is doubled. If ejection fraction is more than in 31 to 35%, this value was taken as 1000 to 2000 in patient without AF and patient with AF. Similarly, if ejection fraction is more than 36, is in the range of 36 to 40%, then this value is 2500 and 5000 respectively. So similar trial was also being investigated, like Emperor preserved trial in patients with preserved ejection fraction, and the results will be published in 2021, and we are very enthusiastic about the results of this Emperor preserved trial. So this trial is global in nature, and it is in almost 520 centers, and it is involving almost all the part of the world. Like it is taking patients from North America, Canada, Latin America, Europe, East Asian. So this is the Emperor-reduced trial. You can see that in this trial, similar trial was published in NEJM for the Empagliflozin molecule, that is DAPA-HF, and both the trials are complementary in nature. They are complementing each other because the results were almost similar. The results were almost concordant in these two trials. So But in this trial, what we have done in this trial, we have taken the patient with high risk with lesser ejection fraction, as well as patient who have annual rate of cardiac event rate is expected to be more than at least 15%. So the population which were taken in this reduced trial, it was a little bit on high risk side of our patient profile. So what we have already discussed the various important mechanisms which are important in this uh, important for reducing the incidence of heart failure, hospitalization, and cardiovascular morbidity and mortality, which already we have discussed that this molecule increases the fasting level of ketone bodies by this was the hypothesis for by given by Mr. Bonnet et al. That this changes the cardiac energetics, and it gives us highly efficient fuel like ketone bodies, beta hydroxybutyrate for energy availability for failing cardiomyocytes. Second one is it also inhibit sodium hydrogen exchanger, which by inhibiting this exchanger, it reduces the cardiac injury, hypertrophy, cardiac fibrosis in the myocardium, and it is also helpful in reversing the remodeling process, which is very important mechanism for the uh, for the heart failure patient. The action of empagliflozin to prevent calcium overload may explain why the drug prevent the time-dependent decline in systolic cardiac function seen in experimental pressure overload induced heart failure studies. So, by reducing this calcium and sodium overload in the cardiac myocyte, it helps us in improving the uh, LV hemodynamics. It reduces preload and afterload, and also it is improving the cardiomyocytes energetics, which is helpful in patients with reduced ejection fraction as well as in patients with preserved ejection fraction and patient with diabetes or patient without diabetes. So the composite primary endpoint was time to first event of adjudicated cardiovascular death or adjudicated heart failure hospitalization in patient with reduced ejection fraction. So these are the various mechanisms which we have already discussed. So Milton Packer was the main investigator of this trial. Primary endpoint were composite of cardiovascular death and heart failure hospitalization. And first secondary endpoint was total number of events, cardiovascular events, first and second heart failure hospitalization. And second secondary endpoint was slope of declining glomerular filtration rate over time. So, so the goal of this trial was to assess the safety and efficacy of empagliflozin in patient with symptomatic heart failure with reduced ejection fraction, irrespective of diabetic status. Study design: patients were randomized in a 1:1 fashion to either receive empagliflozin 10 milligram or matching placebo. All the patients were receiving appropriate treatment for the heart failure, which was guideline directed. Total number of patients in screen was 7,220 patients, and out of that, 3,730 patients were randomized, and total duration of follow was 16 months. Mean age was 16 years in our population, and percentage female percentage was 24%. So inclusion criteria was we have already discussed that patient with adult patient more than 18 years of age, chronic heart failure patient having symptoms which was ranging from class 2 to class 4, ejection fraction of less than 40%, heart failure hospitalization within 12 months, and anti-proBNP, which we have already discussed that anti-proBNP of more than 600 picogram per ml if ejection fraction is 30. If ejection fraction is 31 to 35%, then it is the value is more than 1000 picogram per ml. And if the ejection fraction more than 35%, then the value is 2500 picogram per ml. And if AF is there, then these thresholds were doubled. So exclusion criteria was acute stressful conditions like ACS, stroke, transient ischemic attack, patient listed for orthotopic heart transplant, or patient was on LVSS devices. Other patients like cardiomyopathy patients with infiltrative or accumulative diseases, muscular dystrophies, severe valvular heart disease, acute decompensated heart failure. So basically, the patients, stable heart failure patients were taken in this trial, and patients with the ICD or ICRT devices implanted within 3 months. So salient features of this trial is patients, 18% patients were Asian and 70% patients were white. North America, I have told that this is a global trial involving all the population of world. Patient with NYHA class 2 were taken and the population was 75%. So the more number of stable patients were taken. Ejection fraction was 27%, mean ejection fraction was 27%, and 50% patients were diabetic. Estimated EGFR was less than 60 ml per minute per meter square in almost 48% of population. So medications, so ACE inhibitor ARBs, patient on ACE inhibitor ARBs, they were 70%, on ARNI 19%, MRAs 71%, beta blocker on beta blocker 94% was percent patient was on beta blocker. On ICD, 31% patient were on ICD and 12% patient was were on CRT. So primary outcome cardiovascular death or heart failure hospitalization uh, for patient with empagliflozin arm as compared to placebo. So the outcome was 19.4% in patient with empagliflozin arm as compared to placebo arm with hazard ratio of 0.75. So almost 25% reduction was seen in empagliflozin arm. Cardiovascular death was 10% and 10.8% in empagliflozin versus placebo arm, respectively, with hazard ratio of 0.92. So there was a slight decline in cardiovascular death, but it was not that much significant as it was seen for heart failure hospitalization. So, the primary outcome was primarily driven by this heart failure hospitalization, and cardiovascular death was also there. The benefit for in reducing this cardiovascular death in empagliflozin arm was also there, but it was not that much significant. So you can see the primary endpoint composite of cardiovascular death or heart failure hospitalization was there was a 25% reduction in empagliflozin arm as compared to placebo arm, and it was statistically significant. The first secondary endpoint means the total number of hospitalization, including first and recurrent heart failure hospitalization. It was 30%. It is also statistically significant. Secondary point, slope of decline in EGFR over time, it was 50%. So it was shown that in empagliflozin arm, 50% decline in renal event was seen, and it was statistically significant. So this is what we have already discussed. We have seen that in this cumulative incidence curves, the separation start in the very beginning, and the benefit was persistent throughout the follow. So hazard issue. So the primary point of cardiovascular death and heart failure hospitalization, it was decreased by almost 25% in empagliflozin group as compared to placebo group. So this is the another projection in which we can see that the cardiovascular death and hospitalization for heart failure was significantly reduced in empagliflozin arm. Similarly, the renal protection and renal outcomes were much better in empagliflozin arm as compared to placebo, and it was statistically significant. So, Emperor reduced trial has major implications for clinical practice because this trial will have a major impact on management of patient with chronic heart failure, patient with reduced ejection fraction, whether they have diabetes or not, because uh, they are giving us a very good reduction in death as well as reduction in cardiovascular morbidity also. So patients' quality of life after seeing this, if we will add this molecule empagliflozin in our patient, whether they have diabetes or not, because both this emperor reduced trial as well as this tapa hf trial, it showed that patient's heart failure hospitalization was significantly reduced, and also the cardiovascular mortality is also reduced in patients having SGLT2 inhibitors in their armamentarium for the management of heart failure. These are the same thing which we have discussed. This is the tabular form. The hospitalization for heart failure was significantly reduced in empagliflozin arm as compared to placebo. And death from any cause is also significantly reduced in it was reduced but not that much in empagliflozin arm as compared to placebo. So this is the same thing which we have already discussed, that primary composite endpoint in Emperor reduced trial, it was the cardiovascular mortality as well as hospital heart failure hospitalization. It was significantly reduced in empagliflozin arm as compared to this placebo. And first hospitalization for heart failure was also reduced significantly, and cardiovascular death, it was reduced with hazard ratio 0.92. So both the cardiac morbidity and mortality, it was shown that it is reduced by the adding SGLT2 inhibitors in our standard of care medications for heart failure. So total number of hospitalization, you can see that the same thing, this curve starts separating from very beginning, and the effect of this empagliflozin molecule is persistent throughout follow. So with the help of this molecule, we can reduce the cardiovascular morbidity as well as mortality. So safety wise, this molecule is safe. So initially we were thinking that this molecule is associated with various adverse events like volume depletion, euglycemic diabetic ketoacidosis, UTI. So if you see the adverse event, it was on the little bit on the higher side in empagliflozin, but it was not significant. So we can start this molecule in our patients of heart failure, uh, whether they have diabetes or not. So same thing we have discussed that this trial was global in nature, and it included patients from almost 520 centers. Patients taken from NYG class 2 to class 4, with the more number of patients were from class 2. Median follow-up was 16 months, and almost 50% population was this diabetes. So what we have seen that almost 19.4 the cardiovascular or hospitalization for heart failure events were 19.4% in empagliflozin arm as compared to placebo arm, where the incidence of this primary endpoints were 24.7%. So among the patient receiving recommended therapy for heart failure, those in empagliflozin group had a lower risk of cardiovascular death or hospitalization for heart failure than those in placebo group. So regardless of the presence or absence of diabetes. So secondary endpoints, if you see the composite renal outcomes like chronic hemodialysis, renal transplantation, or decline in EGFR, it was lesser in empagliflozin group as compared to placebo, which was statistically significant. All-cause mortality was 13.4% in empagliflozin arm as compared to placebo, which has shown that the all-cause mortality was almost 14.2%. New onset diabetes was 11.2% in empagliflozin and 12.1% in the placebo arm. And these are the systolic blood pressure reduction was 2.4% and 1.7% in EMPA versus placebo arm respectively. And hypoglycemic events were 1.4% in the empagliflozin arm as compared to placebo. So results of this trial indicate that empagliflozin is superior in improving the heart failure outcomes among the patient with symptomatic stable heart failure with reduced ejection fraction who are on baseline guideline directed medical therapy irrespective of diabetes. Benefit is primarily driven by reduction in heart failure hospitalization. So it is very good drug in reducing the cardiovascular morbidity. There was also benefit in renal outcomes. So renal protection is very good, and it was proven in both the trial, DAPA-HF trial, as well as this Emperor Reduced trial, and many more trials are coming like DAPA, CKD, uh, EMPA kidney trial. They will give us uh, the results of renal benefits. We'll see in future. The results will be published in, I think, in 2021 or 2022. So there is a very important trial and mirrors similar finding from the DAPA-HF, which already we have discussed, that these two trials are complementary trials. Even the Mr. Milton Packer in his interview, he said that these two trials are sister trials, and their results are almost concordant in reducing this empagliflozin molecule, and dapagliflozin molecule is helpful in reducing cardiovascular morbidity and mortality by almost same risk reduction was seen in both the trial. 30 to 35% risk reduction was seen in both the trial. So even though SGLT2 inhibitors were introduced as the for diabetic patient management, the EMPA outcome trial, it showed that a patient with established cardiovascular disease, they can be benefited, and we have seen that almost 35 to 38% reduction in cardiovascular morbidity and mortality was seen in that EMPA outcome trial. The trial enrolled a dedicated heart failure population and conclusively shows that patient can be benefited who's having this increased cardiovascular risks. So, so guideline, what guideline speaks in 2019 ESC guideline says patient with increased risk of atherosclerotic cardiovascular disease or patient is having high or very high cardiovascular disease, they should be started with this SGLT2 inhibitor or GLP-1 receptor agonist. So these two drugs having cardiovascular benefit. I think Dr. Salvi has already told that from 2008 2009, the treatment for diabetic patients are broad and they are assessing the cardiovascular risk, and after assessing the cardiovascular risk, they used to give these molecules which are showing very good results in reducing the cardiovascular morbidity and mortality in diabetic patients. ACC-HA guideline also says similar thing. Patients having cardiovascular disease or multiple risk factor, they should be given consideration for starting this SGLT2 inhibitor or GLP-1 receptor agonist. So these are the future trials which were coming and which were showing that empagliflozin can be given in patients with myocardial infarction and helpful in reducing the events in patients of AMI. Patients with heart failure with preserved ejection fraction. So many trials are going to come in future on 2020 or 22, 24, like EMPA, Preserve HF trial, Define HF trial, Embrace HF trial. The EMPA heart failure trial, it also showed that patient with preserved ejection fraction, they can be given this molecule because it is helpful in reducing the remodeling process, as well as it is helpful in reducing the LV mass, as well as uh, uh, it is helpful in reducing the cardiac cardiac myocyte energetics by increasing the availability of efficient fuel like ketones. So the effect of empagliflozin arterial stiffness was already discussed. It is helpful in reducing this stiffness, and by reducing the stiffness, it is helpful in reducing the afterload, and after by reducing the afterload, we can help our patient by improving the uh, LV hemodynamics. Endothelial functions, we have seen that it is also helpful in reducing the endothelial uh, dysfunction. And one trial is coming, which will be publishing its data in 2021. So the heart failure is the most debilitating condition, and there are a lot of unmet needs which we have to which we have to which we have to fulfill in coming days. And many more trials are coming, which are showing that this molecule SGLT2 inhibitor is very good in patients having heart failure with reduced ejection fraction, as well as patient with heart failure with preserved ejection fraction. These molecule is also very good in reducing the cardiovascular morbidity and mortality in other subset of cardiac patient like MI patient and LVH patients who are having dyspnea on exit. So this molecule is showing a lot of promise in various subsets of cardiovascular patient. Thank you.
Yeah, thank you, Doctor, for Dr. Avinash and Dr. Saki for your presentation. We have don't have any question till now, but one question is: do you think empagliflozin will be a game changer after this trial?
This question is to.
In both cardiologic and diabetologic aspect, after this Emperor HF trial, do you think empagliflozin will be a game changer compared to other SGLT2I according to the cardiac perspective, and compared to metformin in diabetic perspective?
If you ask me, definitely it is not going to be a game changer as compared to other intra-class rivals like dapagliflozin. Dapagliflozin also shows a lot of promise. So I think it is a benefit shown by this class of drug. So there may be some edge, like and they may be attributed to the selection of inclusion, or the criterias of inclusion criteria, inclusion inclusion criteria. So like if you are selecting more sicker patients, so it also means that there may be more benefits, because we know that if the ASCVD risk is high, that the benefit would be more. So it also will have to be seen that the benefits which we are seeing with one study is is different due to different patient selection, or it is just due to different property of that molecule as compared to the other molecule. So it is definitely a wonderful class of drug in selected group of patient. Overall, as we are accumulating more data, whether it is DAPA HF or it is EMPA-REG heart failure trial, so it is definitely more encouraging that we can use this, and then we can fill those void, because we know that there may be a lot of patient with diabetes who are having heart failure with normal ejection fraction, and we can't have a, a lot of option in those patients. So and we know that the most number of patients with diabetes is contributed by type 2 diabetes, and obesity is contributing to a lot of morbidity, and that can also be addressed, which is not addressed by a lot of drug. So GLP-1 receptor agonist is also a class which has a high potency in terms of glycemic efficacy, but that is an agent which is having an injectable nature, which itself is a cause of anxiety in many of your patients when you offer them. So definitely the scope is increasing for any SGLT2 inhibitor, as they are showing promise in their in their trials with these encouraging data.
Okay, thank you. Dr. Saki, we're running out of the time. Can you just give a one-liner or two-liner about this point that empagliflozin may be a game changer with metformin?
I've already given.
Avinash, Dr. Avinash, I'm sorry, Dr. Avinash.
Metformin?
Yeah,
Actually,
empagliflozin
what
can
I
just
just
a one
want
or two
to add
liner.
in
Yeah.
Dr. Sakib's perspective about this two molecules. I have read this both the two studies, and I have seen that the emperor reduced trial, it included a lot of patient who's more sicker as compared to patients which were taken in the DAPA-HF trial, as well as one more thing which is very important. In emperor reduced trial, patients they were more on guideline directed therapy, so the baseline group which was there in placebo arm, so comparing to this placebo, the mortality as well as heart failure hospitalization, it was lesser in this emperor reduced trial as compared to DAPA-HF trial. But both the trials are complementary, and we can say that the class effect is seen in reducing the cardiological morbidity as well as renal protection. So the class effect was seen in these two groups, but mortality was slightly better decreased by this empagliflozin molecule, because the first in the first empiric outcome trial, it has shown that in established heart disease patients, the mortality was significantly reduced by this empagliflozin molecule. But we can't say that this molecule is better than the dapagliflozin molecule, because many more trials are going to come in future, and then we will see whether all the factors which is being tackled by this SGLT2 inhibitor is showing in all the glyphosins. So we have to see the results which is coming in the near future. So I think right now we can't say that this molecule is better than dapagliflozin, but still because of high risk patient taken in this trial, emperor reduced trial, we can say that this molecule has edge over dapagliflozin molecule.
Okay. Thank you, Dr. Avinash, Dr. Saki, for a wonderful presentation and sharing your experience. And we're concluding the session. And on behalf of Lupin, we thank you both, and we'll see you in the future meeting. Thank you very much.
Thank you everyone for listening, and thank you, Lupin, for providing this opportunity. Thank you, Dr. Avinash. Thank you.
Thank you, Dr. Saki.